option offered for these patients with difficult to treat dyskinesia? Right now in the Philippines, we do have DBS, but I think largely the experience is on XDP because they have had research on XDP here. And I think only, of course, the cost is the other major limiting factor. But I guess for patients with PD who are relatively early on in their disease, and let's say for those who will be able to afford, when do we advise them that DBS may be the appropriate treatment?
So it used to be that surgical options were only offered when people were more advanced and not responding to medications as well, when they have motor fluctuations or dyskinesias. Now we're finding that as early as 4 years into the Parkinson's disease, so long as they are tremor predominant, which is a symptom that does not always respond to medication, they may be a reasonable surgical candidate. The decision of early DBS versus late DBS, however, is still something that is very much a matter of discussion between patient and doctor. So there is no hard and fast rule, and it's still a controversy in neurology and in movement disorders as to whether there is really a benefit to doing DBS early versus later on. But it can be effective even as early as 4 years.
Right. Thank you. And it's really good to know that even as early as 4 years, you could already start planning because here it's mostly majority is out of pocket. So our patients really need to prepare for a costly intervention like that. We have another question here. Are there any important comorbidities of Parkinson's disease that we should address?
Yes, yes. When I was talking about the non-motor symptoms, it's a whole topic altogether, but there are so many comorbidities, so many non-motor symptoms of Parkinson's disease that are just as debilitating as the motor symptoms. Depression, anxiety, dementia can all occur with Parkinson's disease and must be addressed and treated. Parkinson's disease psychosis is another condition that occurs with Parkinson's disease. There's autonomic dysfunction, so orthostatic hypotension, constipation, um, cardiac arrhythmias. So all of these things can occur with Parkinson's disease as well. So yes, um, for a talk like this, we want to focus in just very specific topics, but there is so much more to talk about with Parkinson's disease as we learn more and more about the condition.
Thank you for that. I think there is another question here. Is there any way to recognize very early signs and symptoms of Parkinson's disease? Because as you know, a lot of times, especially in the Philippines, patients don't come to us until the symptoms are already severe, obvious. Are there any particular signs and symptoms that would be kind of good to recognize early on?
Yeah, so the cardinal symptoms of Parkinson's disease are bradykinesia, which is slowness of movement, plus one more of these three symptoms: resting tremor, rigidity of the muscles, and postural instability. So those are the four cardinal symptoms of Parkinson's disease. To make a diagnosis of Parkinson's disease, you have to have bradykinesia plus one of those other symptoms. And then, of course, you want to rule out other secondary of these symptoms that can look like Parkinson's disease. When you talk about early symptoms, we're talking about premotor symptoms of Parkinson's disease, but I don't think that you should use that to make a diagnosis early on. To make the diagnosis, you have to have those physical symptoms already. In retrospect, however, what is interesting is that when you see that somebody has a resting tremor and you're not sure whether it's essential tremors or Parkinson's disease, you can ask about these premotor symptoms: loss of sense of smell, constipation, REM sleep behavior. And if you have particularly REM sleep behavior and loss of sense of smell, the likelihood is higher that that person actually has Parkinson's disease. So when you have constipation, loss of sense of smell, REM sleep behavior, Um, these are symptoms that can occur decades before the onset of the first motor symptom. So, in retrospect, it's interesting to ask patients about this, but I would not use those as the basis for making the diagnosis when they do not have the cardinal features.
Thank you very much. We have a question here from Dr. Wilkos Parcon. His question is there a pharmacogenomic treatment modality for PD?
So that is something that is of greater interest now. Not yet, but personalized medicine is pretty much the breakthrough in all of the fields of medicine. But at this point, no, we do not have that.
All right. I think that's our last question for. Oh, there we have one more question. Sorry. Someone punched in a question. How would you advise family members who are taking care of a Parkinson's disease patient in terms of trying to take care of this patient at home?
Yes, so I think that early on, it is not as much of a challenge to keep your loved one well. As I was showing in the slides before they conked out on me, the early Parkinson's disease patients are very responsive to medication. So they do well loved one take their medication exactly on time. So that becomes crucial because when they wear off, it becomes more difficult for them to kick back on. So taking the medication exactly as scheduled helps them stay in the on state much more frequently and on a more stable manner throughout the day. In addition to that, being aware of all of the non motor symptoms, as we discussed earlier, is important because you want to address depression, you want to address anxiety, you want to know if your loved one is having hallucinations or paranoid delusions. And if you find that they are having these other symptoms, then to address it with their physician. One other thing that becomes challenging for family members is when their loved one with Parkinson's disease starts falling. So that's another major challenge in Parkinson's disease. And there are so many reasons for falls. So trying to figure out what you can do to prevent the falls is going to be important as well.
Thank you. There is another question here. What would be the best, or is there an optimal drug to take or give in combination with your levodopa to prevent the dyskinesia?
Yes, so all of the medications that I discussed in the presentation are effective for adjunctive treatment with levodopa, meaning that they do improve on time, increase on time, decrease off time. But you're right, many of these medications will then potentially induce or worsen dyskinesias because they're trying to increase dopamine and therefore overshooting and getting to that point when people will have the dyskinesias is potentially going to occur. There are medications that are specifically used for dyskinesias to counteract this effect, and that is amantadine. I didn't include it in my presentation because I was primarily talking about treatment of motor fluctuations or off states. But amantadine can be used to decrease dyskinesias. There is a formulation of amantadine here in the US called Glucovri. It's a novel amantadine formulation that was shown in clinical trials to improve on time and as well as treating dyskinesias. There is also the possibility that the new medication I mentioned, safinamide, with glutamatergic properties, can also improve on time without worsening dyskinesias.
Um, Another question we just got: how do we manage the coexistence of depression and Parkinson's disease? And how prevalent is depression in patients with PD?
Yes. So the management of depression in Parkinson's disease is no different from the management of depression in people without Parkinson's disease. So it's SSRIs, SNRIs, and any of these medications can also be effective. The only caveat would be that using adjunctive antidepressants, which are dopamine receptor blocking agent class, is contraindicated. So you know how we would treat people with the SSRI and add on olanzapine or uh, uh, risperidone if they're resistant to the antidepressant. So that would be contraindicated in Parkinson's disease. But any of the antidepressants can also be used for Parkinson's disease as well. The second part of the question was, what was the second part of the question?
How prevalent is depression among patients
Oh,
with PD?
yes. So the range is up to 50% of people with Parkinson's disease can have comorbid depression. So it is very common. A misconception about depression is that people with Parkinson's disease are depressed in reaction to their Parkinson's disease diagnosis, and that is a misconception as well. The pathophysiology of depression and Parkinson's disease is related to the neurotransmitter imbalances that occur intrinsic to the disease itself. And there are many studies that document that people with terminal illnesses do not have as high an incidence of depression as people with Parkinson's disease. And yet, if we were thinking that it was a reactive kind of depression, then that should not be the case.
Um, there's another question here. What occupational therapy programs or implements can be used for patients with PD to avoid tremors and enable them to um, use their hands, like eat with their hands, write properly, and things like that?
Yeah. So occupational therapy, there are no specific programs that I am aware of that address tremors or micrographia in Parkinson's disease. There are many exercises that are being done to try to improve that, but I don't know that there is a specific protocol that has been developed, at least not in our programs, that are specifically addressing the tremors and micrographia. The exercises, though, that are done by occupational therapists, they do the coordination exercises, pegboard exercises, stretch of the hands, and the use of adaptive equipment for the tremors, but I don't know of specific protocols. The adaptive equipment, though, for the tremors, take note that in Parkinson's disease, tremors are resting tremors. So usually activities of daily living because their tremors are more postural and kinetic. So with Parkinson's disease, actually, it's more of the bradykinesia and incoordination that impedes them with their ADLs as regards upper extremities.
There is another question here. Are there any specific dietary recommendations for PD? Does intake of coffee worsen the tremors in PD?
Yes, caffeinated drinks certainly can worsen, and any stimulant can worsen tremors. But the dietary recommendation right now, there's a lot of people are concerned about intake of protein with Parkinson's disease. And the reason for this is that protein can potentially interact with the absorption of levodopa. And therefore, there are some people who will find that if they take their levodopa with a high protein meal, that it doesn't work as well. My recommendation to patients is not to worry about that because then the patients sort of get really vigilant about not eating or decreasing their protein. And not everybody will find that protein interferes or interacts with their levodopa. So I'd say eat the way that you would eat healthy, eat balanced. And if you find that when you take your levodopa with your meal, it does not work well, then and only then do you meal schedules to adjust to that, but not in the beginning. The other thing that we like to talk about is the Mediterranean diet. So there's a lot of research shows that the Mediterranean diet is particularly healthy for the brain cells. So what that is seafood, shellfish, avoid red meats, fruits, vegetables, olive oil, the healthy fats, nuts. So, think of the way that the Greeks and the Southern Italians eat, and that's how we must eat. We should avoid sugars, starchy foods, all of the junk food. There is no role for soda in our lives, and that really is something that any of us should be consuming. The toxicity of these sugary foods is being shown more and more in research, and particularly for neurodegenerative disorders.
Another question we just got: are there any herbal remedies or maybe complementary treatments for Parkinson's disease?
So there are a few naturopathic um, medications that have been looked into. The one that I am particularly interested in is mucuna pruriens, which is almost equivalent to levodopa in terms of its dopamine content. Mucuna is one, kava kava is another that's dopaminergic. So there's a few that contain dopamine. And the limitation of these naturopathic supplements are that research is limited. There really is very or no scientific evidence of efficacy that for any of these substances. But certainly there are a few of these that have dopamine content and therefore actually can be helpful for Parkinson's symptoms.
I think that's very helpful to know that because, as you know, in a country like ours in the Philippines, where resources are limited, we're always trying to find other alternative and maybe if there is some more scientific evidence that maybe that could be explored. Another question: what are the sleep abnormalities associated with Parkinson's disease and how do we address these?
Another talk again. Insomnia and excessive daytime sleepiness can occur, many reasons for that. Restless leg syndrome is also more common in Parkinson's disease. So, yes, it's the whole gamut of sleep disorders. Excessive daytime sleepiness and sleep attacks can be a side effect of medication, as I mentioned earlier. So, watch out for that if they are taking dopamine agonists in particular.
I guess we can take one last question. So, for the last question, is there any particular contraindication or a patient profile wherein you wouldn't start levodopa right away for PD?
Yes, so it used to be that the attitude towards levodopa was that we wanted to postpone the use of levodopa in our patients, and the levodopa sparing strategy was very common up until maybe 10 years ago. More recently, however, the studies have shown that there is no reason to delay the use of levodopa because the side effects and motor complications that we were concerned about, which was the reason for delaying levodopa, actually was not because we started it early, but was more dose dependent. So long as you can maintain the dose of levodopa at 400 to 600 milligrams, then the likelihood of developing dyskinesias and motor fluctuations increases. Um, Personally, in my practice, I usually still do not start levodopa as the first medication if the patient is relatively young. So younger patients with Parkinson's disease have a higher risk of developing these motor complications. Furthermore, with some of the milder medications like rasagiline or dopamine agonists, they can achieve good symptom control if they're still pretty early, and we can still save levodopa for later on because they have many more decades of living with their Parkinson's disease, and therefore we want to stretch out the armamentarium that we have over all those years.
Sorry, we have two more pressing questions. It would be important to address these two questions. So, first question: does the social and cultural milieu affect the progression of PD?
Um, I don't know in
Difficult.
what
Yeah.
context that question is being asked.
Yeah.
So, if that is referring to a patient's social status,
Mm-hmm.
then I think that that would be related more to access of treatment. Um, that I don't know the context in which the person is asking that question. So if you're referring to social status, then certainly the limitation of that and the challenge is going to be access to treatment. But if you're talking about social um, opportunities, meaning a person is isolated, then yes, that can also affect Parkinson's disease in the same way that it can affect any chronic disorder, in that in the absence of socialization and activities that are more activating, then symptoms can get worse. But as regards affecting the progression of the disease itself, the pathology itself, then no. The effect on the disease is going to be more symptomatic and more in terms of the ability to treat it.
So, for this last question, we wanted to ask this. We got a question because right now, medical marijuana is a very, very hot topic. Yes, uh, in the Philippines, especially, they've been trying to pass legislation to legalize medical marijuana. And actually, as neurologists, we have been frequently involved, even in Senate hearings, to talk about where is the ability of medical marijuana for neurologic disorders. So, have you been using, or is it being used there for the treatment of Parkinson's disease?
So, Parkinson's disease is one of the indications that have been legalized in many states with medical marijuana. And I was again offering to give a talk, a whole talk on that topic as well. Medical marijuana or cannabinoids, in theory, have very, very interesting properties. And absolutely, the CP component of marijuana can potentially have benefits. The limitation is, again, scientific evidence. So, all the years that marijuana has been legalized, but illegal and criminalized, there has been no opportunity to do research. And even now that it's legal in the US, it's still very difficult to conduct clinical trials for marijuana because it's still illegal federally. So, in theory, there could potentially be benefits to cannabidiols, but in reality, we have no evidence for it. So there is a lot of interest in medical marijuana for many different, not just neurologic symptoms, diseases, but for many different medical illnesses. The neuroprotective property, the immunologic properties, so many potential benefits that we would love to be able to study further.
All right. Thank you very much, Dr. Demarcaida. Thank you for all those questions to our viewers. And thank you again, Dr. Demarcaida, for enlightening. We learned from our webinar today that the efficacy of levodopa changes with the progression of PD. And it's very important in the management of PD, not just to improve the on state, but to also manage the motor fluctuations, because managing the off state and the toxicity, such as the dyskinesias, is also important. We also learned that there are various other medications available for the treatment of Parkinson's disease symptoms apart from your levodopa, and there are also surgical options that may be offered to our patients. So, with that, we would like to thank Dr. Joy Antonell de Marcaida for taking time out of her busy schedule and for including us in her Thanksgiving dinner for tonight. For the Spirituality in Aging webinar. Again, thank you to our sponsor for this webinar, Torrent Pharma Philippines.
Thank you all.
Please also join the Advent webinar about faith and prayer in illness on December 6, Friday, 12 p.m. for the benefit of Pontificio Colegio Filipino and the upcoming UP Med webinar about dengue and polio by Dr. Anna Ong Lim on December 9, Monday, 12 p.m. So these are, watch out for the release of our Aging and Longevity webinars ebook this March 2020. It will contain 24 chapters on the topics discussed in our webinar. So please stay tuned for that. Again, these are Dr. Kimpo and Dr. Demarcaida signing off. And please stay tuned for some reminders.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. To receive your certificates of attendance, kindly answer the evaluation through the link that will be sent to your email addresses after you sign the attendance sheet for today's webinar. The certificates will then be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at